Gracias.
Bueno, hello everyone, hola a todos. En primer lugar voy a contarles brevemente y presentar a los panelistas en español, luego se va a pasar a la webinar a hacer en inglés. Y la idea de la última webinar del año, siempre hacíamos las experiencias y compartíamos. Hoy vamos a hablar un poco del seguimiento a largo plazo del postrasplante. Luego será correctamente presentada la doctora Rachel Phelan del CIBMTR. Y vamos a contar con 3 panelistas que han podido participar de este trabajo, que son la doctora Belen Rosales, que es jefa de trasplante de médula ósea del Instituto de Trasplantes y Alta Complejidad de la Ciudad Autónoma de Buenos Aires; el doctor Amado Karduss, director del programa de trasplante hematopoyético en la Clínica de las Américas en Medellín, Colombia, es el past president del Grupo Latinoamericano de Trasplante; y la doctora Adriana es del grupo de trasplante de médula ósea de pediatría del Hospital Samaritano de San Pablo en Brasil, integrante del grupo de la Sociedad Brasilera de Trasplante de Médula Ósea y también del grupo latinoamericano. Vamos a solicitar que los que no vayan a hablar, que tengan muteados sus micrófonos, pueden pedir la palabra si así lo desean, o escribir en el chat en español o en inglés para poder ser traducido. Ahora le doy paso a Belén. Ahora we talk in English. Adelante, Belén.
Okay, thank you, Mariana. You can see the screen? No, no.
Not yet.
Not yet. Let me a minute. Now?
Yes.
Perfect. Well, good afternoon, colleagues. We meet today in order to show the last update of the international recommendations for screening and preventive practice for long-term survivor of transplantation and cellular therapy. As you may remember, these guidelines were originally published in 2006, and then I update at 2012. As the article states, with the expansion of new indications, better international access, improved outcomes, the population of long-term survivors is growing fast. And however, survivors face serious medical issues that often impact quality of life and decrease life expectancy. So for that reason, prevention and recognize of late effects followed by prompt intervention are crucial to improving long-term outcomes in survivors. This is why we are already here today, and I have a great honor to introduce Dr. Rachel Phelan. She's is an associated professor of pediatric, the Medical College of Wisconsin, Children's Wisconsin, where she specializes in pediatric blood and marrow transplantation for malignant and non-malignant disorders. Dr. Phelan has an interest in late effects and survivorship care following childhood, cancer, and BMT. She's the director of the Next Steps Survivorship Program at Children's Wisconsin, and also serves as the scientific director for the Morbidity, Recovery, and Survivorship Working Committee as the CIBMTR. She has also multiple manuscript and textbooks chapters focused on BMT and care following treatment. So first of all, we are Dr. Amado Karduss will discuss survey exploring long-term follow-up in Latin America, and then we are going to listen Dr. Rachel Phelan talks. And at the end of the talks, there will be time for question and answer. If you want to ask question in English, please raise your hand. And if you want to ask in Spanish, please leave the question in the chat box and we will translate it. So, Amado, when you're ready.
Yes, yes. Thank you, Belen. I am going to switch to speak in Spanish. Muchas gracias por la invitación al Comité de Diseminación y Educación. Como hemos intentado siempre, voy a tratar de compartir pantalla. Me cuentan si la están viendo. Pienso que sí.
Sí, no estás en
Es,
modo presentación.
ok.
Ahora sí.
Perfecto.
La idea de estos webinars es siempre tratar de traer un poco la experiencia o auscultar un poquito qué se está haciendo en Latinoamérica en cada uno de los temas que estamos tratando en el webinar. Este webinar, como ya muy bien lo contó Belén, son unas recomendaciones internacionales en las que tuvimos la oportunidad de participar el Grupo Latinoamericano de Trasplante y la Sociedad Brasileña de Trasplantes, que nos va pues a presentar con muchísima profundidad la doctora Rachel, pero tratando de auscultar un poquito cuál es la condición, cuál es el estado actual de las clínicas de sobreviviente a largo plazo que estamos en Latinoamérica. Diseñamos una encuesta que se practicó, se realizó en octubre, tratando de saber en ese momento qué estaban haciendo los grupos latinoamericanos. Esta encuesta se mandó a través de SurveyMonkey por WhatsApp y por email a la base de datos del grupo latinoamericano, y básicamente con la idea de que no fuera engorroso contestarla. Básicamente hicimos 5 preguntas: ¿en qué país está trabajando? ¿Se dedica su unidad? ¿Es de adultos, de pediatría o mixta? ¿Tiene usted un sistema o una clínica de sobrevida, de seguimiento de los pacientes sobrevivientes a largo plazo organizada o razonablemente organizada? ¿Cuál es usualmente el periodo por el que usted sigue en su clínica sus pacientes? ¿Por cuánto tiempo usualmente? Y comentarios. Tuvimos entonces respuestas de 58 centros de Latinoamérica. Eso equivaldría más o menos al 20-21% de los centros que tenemos registrados en el Grupo Latinoamericano de Trasplantes. En la parte izquierda de la diapositiva ustedes ven la última estadística que tenemos recolectada por el Comité de Centros, por Cinti y por Sebastián. Seguramente hay algo de subregistro, pero a 2023 teníamos registrado 271 unidades en Latinoamérica y tuvimos respuesta de 58 unidades de 12 países, lo creo que es razonablemente bueno para una encuesta que hicimos en un mes. El porcentaje de respuesta de acuerdo al país lo tenemos acá. Colombia, Brasil y Argentina fueron los países que más nos respondieron. Después, muy parecido, Perú, Chile, Ecuador, México, Venezuela, Uruguay y, como ven al extremo derecho de la diapositiva, Paraguay. Tuvimos respuesta de la mayoría de los países y del 21% de los grupos, de modo que, aunque no es lo más representativo, creo que sí podemos auscultar de manera general qué está pasando en Latinoamérica con el seguimiento de los pacientes a largo plazo después que pase el primer año. Cuando nos respondieron cuál era la principal actividad de su unidad, el 53% estaba trabajando en una unidad que básicamente hacía trasplantes en adultos, el 17% en pediatría y un 30% eran unidades que se encargaban de hacer trasplantes tanto adultos como pediátricos. Ante la pregunta de si usted tiene un programa formal de seguimiento a largo plazo de pacientes sobrevivientes de trasplante hematopoyético, 43% de los centros respondieron que sí y 56% que no. Si un poco menos de la mitad tienen un programa formal, lo cual me parece satisfactorio para Latinoamérica. Ante la pregunta de por cuánto tiempo siguen ustedes sus pacientes, 17% un año, 1 a 3 años 20% y más de 3 años 63,7%. De modo que casi el 80% de los centros de Latinoamérica que respondieron la encuesta siguen al paciente por lo menos entre 1 y 3 o más años y no un periodo corto, lo cual también creo que es satisfactorio porque hay cierto nivel de seguimiento a más de un año. En los comentarios era como tratar de que nos contaran un poquito qué hacían, cómo lo hacían, tratando de escoger, de seleccionar los comentarios. En cuanto a la periodicidad, la mayoría de los centros siguen a los enfermos semanalmente los primeros 2 o 3 meses después del trasplante, posteriormente mensual hasta completar el primer año y después del primer año 1 o 2 veces por año, y este seguimiento después del año es una mezcla en los centros de visitas presenciales con el paciente físicamente presente, telemedicina y llamadas telefónicas. Lo que más tienden a vigilar, a seguir en estos seguimientos a largo plazo en los grupos son, como esperábamos, la presencia o no de enfermedad injerto contra huésped, tratar de hacer la vacunación post-trasplante y el seguimiento pues, de las afectaciones de endocrinología, cardiología, la parte metabólica, ginecología y urología. Era una encuesta cortica, pero la idea era que se pudiera responder en pocos minutos para que tuviéramos un número suficiente de respuestas. En conclusión, esta mini survey que hicimos en el mes de octubre, la respondieron el 21% de los programas que tenemos registrados. Hubo respuesta de la mayoría de los países latinoamericanos que están haciendo trasplante. Un poco menos de la mitad, el 43% de los centros manifestaron tener algún tipo de programa formal de seguimiento a largo plazo de los pacientes sobrevivientes, y el 80% de los TIN siguen al paciente 1 o más años. Las visitas, sobre todo después que ya pase el primer año, tienden a ser una mezcla de visitas presenciales, visitas por telemedicina y llamadas telefónicas. Y como ya dije antes, esto que están allí son los problemas o lo que tratamos de saber qué le está pasando a nuestros pacientes en los sobrevivientes a largo plazo. Es una encuesta pequeñita, pero era con la idea pues de darnos, pues, de auscultar un poquito qué estamos haciendo en Latinoamérica. Yo quedé gratamente sorprendido de que el 40% de los centros tienen algún tipo de seguimiento a largo plazo estructurado y que el 80% de los centros logran seguir a sus pacientes más de un año después del trasplante. Muchísimas gracias. Aprovecho para darle las gracias a todos los colegas que respondieron, y pues esto creo que sirve de introducción a la siguiente conferencia y después a la discusión. Con esta mini encuesta termino. Muchísimas gracias. Voy entonces a dejar de compartir pantalla para que continuemos.
Oui.
Entonces, Belén, si alguien
Sí.
tiene algún comentario o continuamos con la doctora Raquel.
It's okay. Maybe Rachel, if you are ready now, you can share the screen and we go on.
Wonderful. Can you all see my screen okay?
Yes, perfect.
Great, great. Thank you. So, first of all, thank you so much to all of you for the invitation to be here with you and to share these guidelines. I know many of you have been part of their development, which was quite the project. And so I will call out all of you on the call who helped to make this happen. And also thank you for sharing that data from the survey. It was very reassuring to hear that the vast majority of centers continue to follow your patients long term. So that's wonderful. And as you can tell from what I will talk about, that's clearly important. And hopefully these guidelines will help you as you see some of your longer term survivors in your practice. All right, so this is just my conflict of interest disclosure. And here is the agenda for our talk today. So I'll spend a significant amount of time just talking about project development, so how we all came together to make this project work. Then I will also go over how the guidelines are formatted. Hopefully many of you have had the chance to take a look at them already, but if not, I'll help to guide you through them to hopefully make it easier as you go through the very long document that we did provide as part of this manuscript. Then I will review a few select guidelines if I went through all of the guidelines, this meeting would be much longer. So I'll just pull out a few of them. And then I'll talk a little bit about next steps. And that's something where I would love to have all of your input as well as we think about the future and how we'd like to continue to update these guidelines in a way that would be useful for all of you. So we'll start with project development. So as was already mentioned, the last iteration of these long-term survivorship follow-up guidelines was published back in 2012. So it was around 2022 when we first started talking about the need to update this guideline, since it had been around a decade of time since this had been looked into and updated. So looking back at the guideline from 2012, it did have a lot of information in it that was very useful, including a table that separated out what should be evaluated into 11 different organ system specific sections. And this table is right here. I'm sure many of you used that in your clinics. There are also a number of strengths of the prior guidelines. We wanted to make sure to, again, incorporate those strengths when we made the new guideline. And some of those strengths included guidance on basic recommendation for most organ systems that could be involved, including that one large table. During that guideline development in 2012, they also wanted to make sure that its use was feasible across multiple different medical systems. Within that document, they also included further background and recommendations in the text narrative outside of the tables. They tried to keep the information fairly compact and high yield. We did have to expand upon that because we're learning so much more than we used to know. And it was also important at that time that there was contribution and agreement from multiple medical societies internationally. So back in 2012, 7 different societies were involved when developing the guideline. And we also wanted to make sure that it served as a foundation of follow-up plans for most survivors. So it could be applicable to most of the patients that everyone sees. And at that time, it was really considered to be the standard of care. So I know most people, as I said, had the tables printed out and used it in clinic to be able to decide when a patient needed follow-up evaluations done. But as we all know, a lot has changed since 2012. So this is some data from CIBMTR. And as you can see, and as all of us know, we continue to perform more transplants over time. So this includes both allogeneic and autologous transplants. The red line is 2012, and then it's continued to just grow since that time. There was a little blip right here. I think all of us know what happened back in 2020, but now that's continuing to grow from there as we anticipate as we come out of the COVID era. We also use different transplant strategies when we think about how to treat patients, and that includes increased use of things like post-transplant cyclophosphamide. So whereas back in 2012, only 2% of all transplants used PT-Cy as a platform for GVHD prophylaxis. That compares to 2021. We don't have more updated data here, but as of 2021, over a quarter of patients received PT-Cy prophylaxis. And that, again, continues to grow with time. In addition, we also continue to transplant patients as an older and older age as we find ways to transplant them safely. So again, back in 2012, only 14% of patients were over the age of 65. And then as of 2021, that was already up to 29% of patients. In addition, we have new and innovative therapies that have really come to the front line since 2012. That includes a number of different CAR T cell products. And this is data, again, that is captured by CIBMTR in terms of how many patients are in the registry. And back in 2016, we just had a few. And now, as of 2021, we had over 6,000 patients in our registry that had received CAR T cell infusions. as was also mentioned, because we are doing more successful transplants for more patients, we also continue to care for more survivors. And this is data that's limited to the United States. But as you can see, this study that was published back in 2013 showed a projected 500,000 survivors of transplantation in the United States as of 2030. So if the projection is correct, we are around the 350,000 survivors time point, but that just continues to grow. And it's also notable that a number of these transplant survivors are less than 18 years at time of transplant. And so those patients have many years potentially and hopefully of long-term follow-up and many transitions in care that we need to try to make sure are successful. In addition, we also keep learning more about how to care for long-term survivors and what specific side effects they may experience as they move further away from the acute transplant period. And this is just doing a really quick PubMed search, typing in HCT and late effect. And you can see this red arrow here, again, is 2012, when the last guideline was developed. And between 1979 and 2012, there were only 109 manuscripts that met those search terms. And then between 2012 and 2024 so far, we already have over 340 publications that meet that search term. So we have definitely learned a lot more about how to care for these survivors, what they may be at risk for, how to best care for them. And then in addition, we continue to have more survivors that are likely older and are receiving different and innovative therapies. So with all this in mind, we all were in agreement that we needed to update that 2012 guideline. We wanted to continue to involve as much of an international collaboration as we could. So this time around, we actually included 11 different international societies as we went through this project, and that's in comparison to 7 back in 2012. And 31 members contributed to this project. We also wanted to make sure to include adult pediatric members of the team, so those who care for both types of patients. And we did include patient advocates this time to review the paper and make sure that we were incorporating their voice and their needs as we developed this project. So here is the list of 31 contributors, and the pictures below are kind of the steering committee or the main people who helped drive this, but everybody played a very crucial role. So those in pink are all of you, hopefully. I think I've seen most of you on the call, or at least a large number of you on the call from the SBTMO and LABMT, who really, again, played a very critical role in making sure that this project came to development. So thanks again to all of you for all of the work that you put into this project. So as we came together, this was kind of the design and how we started. So we all met, and as you can imagine, trying to orchestrate meetings with people from all over the world, time zones were very difficult. So we had to have multiple meetings to make sure that we included all of the members to have a formal discussion about how we wanted to approach this. So we all got together, formulated a proposal. We did work with the ASTCT Guidelines Committee as part of this process as well. And then we invited different groups to join this process. And we wanted to make sure to include representatives from the different organizations that had a known interest in late effects. And so that's where all of you came in and helped to make this happen. We then went through a lot of discussion about how we wanted to format this guideline. Again, we wanted to include a lot of the good things about the 2012 guideline, but then also expand on areas that we could improve. We then assigned different sections and divided up work between different subgroups. did a lot of review of draft sections, and then voted on the different guidelines. And when we voted on the specific guidelines, we did use an NCCN-like approach where we asked everybody who is part of this process, number one, do you agree with this recommendation? Yes or no? And then if not, is there a change to the guideline that would lead to your support? So is there something we could change about how it was worded or what was included that you think would make it relevant? And you would say, yes, that is a relevant guideline. We then graded each guideline as either grade 1, 2A, 2B, or 3. And all of the guidelines actually ended up being 2A and 2B, where we had lower level of evidence, but either uniform consensus or consensus that was 50 to 85%. And so that goes to show that although we have learned a lot more about survivorship and late long-term or late side effects, there's still a lot more research that needs to be done for us to get to a higher level of evidence for what we do. So again, grateful for all of you that are taking care of our patients, helping to create more survivors, but we want to continue to work with all of you to make sure we're continuing this area of research. All right, and then just a little overview of the guidelines. So again, there was already a screenshot of what the guideline looked like when it was published. It was published both in TCT and BMT, so it was available in both journals. And in TCT, it is open access, so everybody has access to that. So I just want to make sure that you all are aware of it. It was published on February 27th, 2024. So what is new in the manuscripts? There are a few new topics and the organization is a little bit different. So we did add a hematopoietic complications section to the manuscript. We'll talk a little bit more about that. We significantly expanded upon the psychosocial adjustment, cognitive dysfunction, and quality of life recommendations. There was a little section on that in 2012, but we've learned a lot more since that time, so definitely expanded on that. We did include updated vaccine guidance, and we also included return to work and return to school guidance, as well as transition resources, in particular transition from pediatric to adult-based care. We did update recommendations on subsequent malignant neoplasm screening, and we'll talk a little bit more about that. And then we also made sure to include special population guidance. So this was based on some rare diseases that we do transplants for that may require different or separate follow-up. That includes patients with autoimmune diseases, hemoglobinopathies, and other genetic diseases, as well as myeloma and amyloid. And then we did also include separate sections on special care for patients who are transplanted as infants, adolescents, or young adults, and then also for patients transplanted in older adulthood. So right here, this is an example of what the tables look like inside the paper. So we ended up separating everything into 16 organ-specific sections. So again, going back to 2012, there were 11. And within the text, we have background, epidemiology, and risk factors that we talk a little bit more in depth about. And then we have tables for most of the organ-specific sections that provide the specific recommendation. So you can see right there what the evidence grade is. So as I said, most of them are either 2A or 2B. And we also here have the key references that helped us to lead to the conclusion or to guide that recommendation. And if you open this online, you can actually just click on the reference and it'll take you to that reference for further evaluation. And then in some specific instances, we did provide further comments or details about that specific guideline to make sure that we explained further when we would recommend this happens and in what particular circumstance. I also want to make sure that everybody is aware of the supplemental appendices. So Sometimes those are a little tricky to find, but you have to click on a separate section when you open this manuscript. And I want to make sure that everybody's aware of them because there is a lot of very valuable information in the supplemental appendices as well. That again includes that revaccination guideline that I had mentioned earlier, a number of resources that can be made available to patients and partners for peer support. I would have to look to see if some of that is available in Spanish, but it's possible. Also resources for returning to school or work. And then also, as I had mentioned, those special populations that we need to pay particular attention to that may require separate or different follow-up. And then also some additional references, again, if you want to look back at the literature that we screened in order to develop the specific guideline. This is an example of one of the other supplemental tables that's again broken up by organ system. So we ended up organizing them 2 separate ways. So one that I showed you previously and also this way in the supplemental materials. And in this way, we actually list the specific late complication that somebody may be at risk for. Then we list the risk factors with a particular attention to TBI and graft versus host disease. We give the recommendation on what we would do for assessments, tests, and preventive measures for routine patients. And then we also call out for any special populations if we recommend doing something differently because of their special needs that they may require. And then down at the bottom, we again provide key references and further reading if anybody's interested. Okay, now I'm going to go over just a few select guidelines, and I always want to make sure that when we go over the guidelines, just a few caveats that I want everybody to keep in mind. So obviously, as many of us know, especially those of us who follow our patients really long term, we know that many of these late effects can take years or decades to manifest. So really, we do recommend that the majority of these guidelines are followed forever. There are a few that we call out that can be stopped at a certain time point, but a lot of them we want to continually check in on the patients on a number of these different topics. The recommendations are also at a broad global population level. And so we always need to make sure that we also incorporate patient-specific risks. And all of you as clinicians know that we're always going to have patients that are exceptions to the rule. So we should always use our own clinical judgment for individual patients. Also, as I mentioned, most of our guidelines relied heavily on expert consensus because of the lack of prospective randomized trials when we're looking at survivorship and long-term side effects. So just make sure that you're aware of that. And that, as we know and as we saw from your own survey that you conducted, survivorship care may take many forms. Some institutions in the US as well do not have a formal long-term survivorship program specific to that. And so you may need to adapt how you use these guidelines to your own practice. And again, a lot of the available data is largely derived from North American and European centers. So it may not be generalizable to every single population. And so implementation of these guidelines, again, may need to be modified depending on what is available. So I am, again, going to speak about just a few of the specific sections. So the hematologic complications section is one of the new things that was added in this iteration of the guideline. And so here is the subgroup that helped to lead this. So I'll give a little shout out to Adriana, who I know is on the call. So she helped with this particular section. And here are just a few, I'll go over a few of these guidelines since this is a new recommendation. So we do give very clear guidance on how frequently we want CBCs to be done in our post-transplant survivors and the duration. For patients who have hemoglobinopathies, we also call out monitoring for them, which may be a little bit different. We talk specifically about iron overload and phlebotomy. and then a few other things that I'll call out and just pull out from the tables. So again, I had mentioned hemoglobinopathies, so in patients with sickle cell disease and thalassemia. So those patients, we do recommend following chimerism at least every 3 months in year 1, and then every 6 months in year 2, and then further chimerism based on those results. And that's just because we know patients can lose their graft after undergoing a transplant for this condition. We also talk a lot about iron overload, and I know this is has become, at least in the US, a more popular topic over the years without a lot of clear guidance on how often we should be looking for iron overload or how we should treat it. So this is actually nice to be able to help guide that. We do recommend, if available, that we not only follow serum ferritin, but also get iron quantification by MRI, since that can be more accurate. And then in patients who have high iron, there may need to also be further cardiac assessment via MRI as well. And post-transplant, phlebotomy is the recommendation to treat iron overload. We also talk about thrombosis in the hematologic complications section, and specifically call out the risk of venous thromboembolism in the patients with multiple myeloma that continue to receive immunomodulatory drugs post-transplant. And also, as we always do, we call out the need to assess the risk of bleeding before initiating anticoagulation. Inherited bone marrow failure syndromes, as we all know, are rare, but when we do diagnose them, these patients oftentimes need follow-up that differs from the typical patient. And so because of this, we do recommend that further consultation with a hematologist that's familiar with that condition be completed. And that may still be yourself who's caring for those patients, but if not, then referral to a specialty center is recommended. So I'll talk a little bit more now about the subsequent malignant neoplasm section. This again is really of particular interest, I think, to everyone. There haven't been a lot of changes in terms of recommendations, but we'll go over just a couple of things. And when we're talking about subsequent neoplasms, we first have to remember that some patients are at risk and some patients are not. And if their risk is not otherwise modified by their transplant history, we really recommend continuing the routine screening as regionally indicated. And then really based on any other medical, family, genetic history, et cetera. So that always is important just in general. We do talk about screening for treatment-related myeloid neoplasms. And the recommendation for that screening is to get an annual CBC until at least 10 years post-transplant, because as we know, after that 10-year since exposure, the risk of developing a transplant-related myeloid neoplasm definitely goes down. But we do need to consider more frequent screening in those with greater risk. And also if we do see changes in the CBC, to make sure that we do further evaluation. We also talk about head and neck squamous cell carcinoma, and especially for those patients who have a history of chronic graft-versus-host disease, tobacco use, or those patients with Fanconi anemia. We make sure that an oral exam is part of every survivor exam, but paying extra close attention to those patients at higher risk. Also, a lot of our guidelines really are focused on patient education. So making sure that patients report things like non-healing oral lesions or changes. And we do recommend HPV vaccination according to country-specific recommendations. So colorectal cancer screening is something that did change from the prior iteration of the guideline. And it really changed based on how we changed screening, at least in the United States. And you guys can let me know if you've changed your age range for colorectal cancer screening as well. But we ended up changing from 50 years of age to start routine screening to 45 years of age for routine screening. So we wanted to make sure to call that out because we would never want a patient, oh good, same here. We never want a patient to start screening later than what the general population recommendation is. Also, as we were going through the literature, there was different recommendations for patients who are transplanted at the pediatric age compared to those in the adult age. And so whereas everything used to be one general recommendation, we actually split it up into pediatrics and adults. And we recommend the screening really depending on whether or not they had radiotherapy or, total body irradiation exposure. And so it may occur a little bit sooner than 45 years of age, depending on when they were transplanted and if they were exposed to radiation. So some of our patients may undergo screening as early as age 30. So just really important thing to always reference and look at and see, does my patient require screening even earlier than that general population 45 years time point? Breast cancer recommendations actually have stayed the same as they were in the last guideline. So that's one thing that I've gotten questions about since publication of this, because we always want to make sure that it's, at least in the US, covered by insurance and consistent with the guideline. And so the recommendation is still that female recipients who received total body radiation or prior chest radiotherapy begin breast cancer screening, and we recommend with mammogram and breast MRI at age 25 or 8 years post radiotherapy, whichever occurs later. So you may have a patient that got a transplant at age 25, right? But we don't want it to occur any later than age 40, because again, 40 is the general population screening recommendation. And we did add, just noting that patients who have even a higher risk, so notably those who have genetic mutations that would place them at higher risk, like BRCA1 or 2, or a significant family history, that we would recommend referral to specialists to talk about potential risk reduction strategies. So we do call that out because we do know the addition of transplant to some of those potential genetic factors only further increase their risk of developing breast cancer. All right, so then I'm going to talk a little bit more about next steps, and then hopefully it looks like we'll have a little time for questions, which is great. So again, this was a huge effort by many people across the globe. We're so excited that we have it available to share with all of you and to use in the clinic. We have done a lot to try to make people aware of this guideline and how to use it. And so we did update the NMDP website, has a nice, different format for showing these tables. So it's kind of nice if you want to go there. They have pretty color tables and things like that can be downloaded and used separate from the actual manuscript. We also have given a webinar through the NMDP, so hoping again to spread awareness of these updates. We're doing conference presentations, like right now. I'm joining your LABMT conference, so again, hoping to share this with all of you. We have worked with ASTCT and given some talks at their survivorship SIG meetings. And we also are working with ASTCT to update their mobile app. So I don't know if any of you have the app or have used the app, but their app does currently have the guidelines from 2012 on it. So we want to make sure that we're updating that to the new guidelines. And then a couple things that we are still exploring. So one is language translation. Obviously, we worked with you and with others from across the globe where English might not be the primary language, and we want to still make sure that this is accessible. And so we have investigated and looked a little bit into that. And I know that we reached out to maybe some of you to talk about that, but I'd be happy again to discuss and explore that with you. And then one other thing that is all on the top of all of our minds, and again, I would love to connect with any of you that are interested, or you can give us your thoughts, is how frequently we should continue to review these guidelines and update them. I think everybody would agree that we don't want to wait another 10 years because the field really is continuing to expand and we're continuing to learn so much more. You know, there's a lot of research that's being done in this area, new reviews, new therapies. You know, another thing that we very lightly touched on in the guideline are things like CAR T cells and gene therapies. So I'm sure by the time this is updated next, we're going to learn even more about things like that. The way we collect data is different. The way we collect data from patients, I think, is also really critical, and we may want to incorporate more of that. So a lot to be learned, a lot that we continue to learn, and we want to make sure that this effort continues in the future and likely at a more frequent cadence than every 10 years. So again, I just want to give a shout out to everybody who helped make this happen. Thank you so much for being part of our team, those of you who are on the call. And we're also so happy to work with any of you who may be interested in future projects related to survivorship care. And here's my contact information.
Thank you, Rachel. Excellent.
Thank you all. I'm happy to answer any questions you may have.
Yes, now we have time to answer some questions. So maybe, I don't know if in the chat.
Do you mind if I start?
No, of course, please.
Thank
Go,
you.
Ale.
Thank you so much, Richard. Wonderful presentation, wonderful summary. We really thank you. We have a problem here in Brazil that I bet there will be in other countries, that there is no specific diagnosis for being post-transplant. There's no coding.
Oh.
And we have lots of trouble on how to set up these clinics, because what the patients have in common is being transplanted, but they are not in the acute phase. So usually patients are referred to a cardiologist, to a pneumologist, and they, it's not that they don't care, it would be rude, but they don't understand that that patient that looks so healthy would be at very, very high risk of having a myocardial infarct at the age of 30, or having a breast cancer so much earlier. And it's a huge challenge here in Brazil. And I don't know if you would share with us, how do you deal with it in the US?
Yeah, that's a great question. And yeah, I'm sure a challenge for everybody, you know, in different ways across the globe, right? So how it works here is that it's a lot of communication back and forth, which takes a lot of work. We do have some patients who, you know, the easier patients are the ones that stay within our medical system long term. And we do have an adult hospital that is affiliated with our pediatric hospital. And so over the years, our survivorship program has gotten to know, like, there's a specific pulmonologist who has an interest in post-transplant care and an interest in chronic graft versus host disease. There's a specific cardiologist that is a cardio-oncologist, right? So knows what those risk factors are. And so that we started kind of developing and growing this network of people that we continually refer patients to so that they have an understanding. So that's the easy case. But then we also have patients who are coming from far away, right? Who don't have access or the ability to come back to our center to see those specialists. Or in the United States, we have an issue where if we have a patient that got a transplant that's from a different state, their insurance will no longer cover them coming back to us once they cross the state line. So that's a huge problem. So then what we end up doing is we communicate a lot with their primary care doctor. So every patient has a primary care pediatrician or an internal medicine specialist who follows them routinely. And we actually develop a very comprehensive care plan that says, essentially, because they received busulfan, we want to make sure, we follow their pulmonary, like if they complain of pulmonary issues or whatever, just all these things. Because they received cyclophosphamide or radiation, their risk of infertility is higher. All of those things we list out very clearly and communicate to the primary care doctor, who then can also subsequently, hopefully convey that information to the subspecialist that's nearby. We also offer to talk to the subspecialist nearby, especially if we get the report back that sounds like they really didn't get it, right? Like they just ignored it. We're like, okay, now we need to call them and talk to them on the phone. And then I think the other really key thing that we try so hard to do is educate the patient and the parents themselves, because oftentimes, as hard as we try, like people move, people, will encounter a specialist that doesn't understand. But if the patient and family understands what they're at risk for, it's our hope that they can also advocate for themselves. And of course, if that doesn't happen, then that's when we get the phone call and they're like, hey, can you call this person instead? So really, it's multiple layers of education, but it's definitely a challenge in the United States as well.
Thank you.
Mhm.
I also miss tools for the patients, what we are talking about, tools for the patients and families where they can find reliable information to be able to help themselves.
Yes.
The COG has a material very good.
Yeah.
But for the Brazilian kids, it's a little hard to follow. They're a little bit too complicated. And I don't know if our colleagues have tools for the patients and families in Spanish that they know and we would be able to use.
Yeah. Yeah, I know the COG, you might be talking about those health links, Adriana, that are, they do have Spanish translation, but I've never asked. I should ask my Spanish-speaking families what they think of them, right? I've given them to them, but then I haven't followed up and been like, oh, was that easy for you to follow or not? So yeah, and since I'm a pediatrician, I don't do as much, on the adult side in terms of other resources that you have in Spanish aside from COG. But, it's actually interesting because COG did that work. Is that something that, not that any of us need more work, but is that something that we as a transplant community could develop, separate from them and do something similar and available in different languages and vetted by patients and families that tell us this is helpful and makes sense?
Yeah.
That could be another future project.
Yeah, it'll be wonderful.
Yeah.
No, somebody talk. And Rachel, what about the transition between the pediatric and adult patients? Do you have something special, a team or somebody who cares about in the middle? How you manage that?
Yeah, great question. That is also, it varies across places. And depends on the resources you have. So as I mentioned, we have an adult hospital affiliated with our pediatric hospital. We used to have a BMT specialist on the adult side that specialized in survivorship and late effects and had his own late effects clinic, and told me that he actually wanted to be a pediatrician for a while and then changed his mind. So he liked coming to see the kids. But so we set up a whole program where we, at a certain age, so at 21, we were going to transition all of our patients to him. And we were going to do a joint visit, so with a pediatric transplanter and him on the pediatric side, so that everybody would get to know both of him. And then another joint visit where we would go over there with him on the scary adult side. And then unfortunately he left our institution and we had it all set up and it was so sad. So now we're trying to convince another one of the adult transplanters to want to take care of our pediatric patients. So we're currently working on that. But in the meantime, we actually, on the pediatric side, keep following the patients into adulthood. So we just got a referral for a patient who's now 44 years old and was transplanted as a child. And she really doesn't have anywhere else to go, right? So what we do then is like what I talked about before, where we will put together a care plan for her, review all the treatment she received, you know, order and discuss what labs or imaging she may need. But then, you know, if she needs an antihypertensive,
Yes.
you know, I don't know. So then we, you know, work with a primary care doctor to help to manage that.
Yes, yes, I understand, and I think many of us have the same problem when you receive the pediatrics patients that grow up and they want to return to with the pediatrics, so it's always an issue.
Yeah, yeah. We just need more people that are interested in survivorship. That would fix the problem.
Yes, that's the problem. Yes, I agree with you. And I think
I have a question. Thank you for your wonderful talk. If a small unit, intermediate unit, in a country with economical constraint like Latin America, wanting to start a survival clinic, what would be your recommendation for the minimum requirement for starting the clinic? Talking about physical facility, but mainly about the number of non-hematologist specialists involved in the clinic.
Yeah. So I can tell you how our clinic is structured, and I feel very fortunate. So I think so sometimes when I talk about our clinic, I'm like, oh, I feel kind of bad because we have a lot of resources, but it works really well. So of course we have a physician. So I'm the transplant physician that works in our survivorship clinic. Our clinic sees transplant survivors and pediatric cancer survivors. So it's both. So some patients that have not received a transplant. So I think that helps maybe to get more resources too, right? Because then we have a bigger patient population. So that's something to consider, doing kind of a combined survivorship clinic with oncology. And then with that, we have also an oncologist and a transplant specialist physician who has this interest and some dedicated time. We also have a nurse practitioner in transplant and a nurse practitioner in oncology that helps to see the patients. We have a nurse that helps to really coordinate everything that's critical, you know, make sure that we get the referrals in, that we get the patients scheduled. And so we have that as a resource. And then we have, like I said, kind of this web of different subspecialists that we work with on a routine basis that we bring into the fold. We also have dentists, physical therapists, psychologists, which are really critical, social workers, and we have a fertility navigator. So some of our survivors who are really interested in what their fertility potential are, we have a person who can talk to them about that. And then we have this really special position that we call a community navigator, who oftentimes when patients come to us or they're transitioning from pediatric to adult care, they need a new primary care doctor, they need a dentist, they need to find a therapist in the community. And this person helps to figure out what their insurance is and who might be interested or capable of taking care of these patients where they live. So that's really nice too. We also start teaching our patients about survivorship early. So we have a program where we start talking about survivorship shortly after treatment so that when they transition to our survivorship program, it's not as big of a change. They've already heard some of these things and met some of some members of the team. And then when we do transition patients from our active transplant clinic to our survivorship clinic, we have a long visit, like an afternoon long visit where they meet all of these people and screen for their needs. So they meet the physician, they meet the psychologist, they meet the nutritionist, we actually have school teachers to see how school's going. So meet with this big long group of people. So we always warn them this visit's going to be 2 to 3 hours, right? Where you meet with all these people. And then, sometimes we find things that you wouldn't have thought because everybody's asking them different questions and, have the time to think about these things. And so that's the first visit they have with us. And then after that, it's just kind of a routine visit with the provider, and we pull in any of those specialists that they might need. So that's how we function. But I know programs that also function with a lot less resources, but that really helps to keep things running very smoothly for our patients.
Do you have some statistic about how adherence are the patients to continue visiting the survival program?
Yeah, so we haven't run those statistics recently, so I don't have those, but we should do that again in terms of loss to follow-up rate and things like that. Like I said, we do have a lot of our transplant survivors that, sometimes we see them and I'm typing their note and I'm like 20 years post-transplant. So a lot of people do come back. I would say the major reason why patients are lost to follow-up is really because, again, kind of that they move, insurance issues. They finally find a primary care doctor that understands what their medical issues may be, that type of thing. But a lot of our patients do stay with our program. And at that point, we offer to see them once every 1 to 2 years to check in and do an assessment.
Yeah.
Okay.
Well,
Mariana says we still have some time. Would you like to, Mariana?
We have a time.
Okay.
Rachel, I have a question or comment. Do you have a problem with the vaccinations?
Oh, yeah. Yes, we do. Do you guys? I'd be interested to see. Yeah, and that's really changed, throughout my almost decade of doing this, right? And that it's just definitely a changing culture in America as well, where which is fascinating to me, because these patients go through so many toxic treatments to be cured, but then still have so much apprehension about vaccination, right? And sometimes it's even as simple as an influenza shot in the fall that we have to spend a bunch of time to convince them to get it. But it's really mixed. I would say we do have some of my patients are like, when can I get the COVID vaccine? I really want to get it. And I'm like, oh, you're amazing. And then, we have others who have never gotten it. And so it takes time. I have had families where, if you have the time to talk through it with them, as you guys all have the experience, I've given in to a lot of modified vaccination schedules just to get the vaccines done. So some families will be like, I will do 1 vaccine per month. And I'm like, okay, we will do 1 vaccine per month. And so it's a tough part of our job now. And sometimes it can be quite frustrating, but we have the guidelines, we have data that we can give patients, but it's definitely an increasing challenge. And interesting to know that you guys have been experiencing the same thing.
Yes, thank you.
well, I think we don't have any question in the chat. Well, Rachel, thank you very much. It was very important for us to listen, to I don't know, to share the same feelings with the patients, with the difficulty of long-term follow-up So, well, for us it's very important to have you here now today.
Of course, of course. And if anybody has questions about how our program works or anything like that, I'm very happy to answer those for you guys. So just please reach out. Okay. And yeah, and like I said, I think we have, Adriana, you guys are all giving me more ideas. So more work to be done. It'll be exciting.
Okay.
It was great.
Great. Thank you all.
Thank you. Thank you.
Well, thank you very
Thank you.
much.
Bye-bye. Thank
Bye,
you.
thanks.
Bye.
Ok. Jenny, creo que terminamos. Podemos ya parar. Muchas gracias.
Gracias, Amado. Gracias por el panorama.